In session 45 of the Falcon Physician Reviews Online, we're going to be discussing the orbit and the eye. The eye exam is going to be an important part of your clinical lives and can be easily tested in the USMLE. In general, though, you're going to have the visual acuity test, which is tested by the Snellen chart, and even color blindness cards. Then you're going to do an inspection of the eye, which is going to be observing for ptosis, exophthalmosis, lesions, deformities, or asymmetries. Then you're going to ask the patient to look up and pull down and look at the conjunctiva and the sclera for any reddened or infected areas. You'll spread the palpebral fissure with your fingers and ask the patient to look each way to ensure that the bulbar surface is okay. And then you're going to notice any discolorations, redness or discharges or lesions associated with the cornea or the iris. Visual field and extraocular muscle testing will be important, and we'll discuss the H-test. Pupillary reflexes, light and accommodation reflexes. And then finally, a fundic inspection, in which you'll use your ophthalmoscope to look at the vessels and the optic disc and inspect outward from the optic disc in at least all four quadrants. And there's another thing that you can do called PERLA as a memory tool, which is abbreviating for checking the pupils if they're equal, round, reactive to light and accommodation. You want to make sure you don't get lazy on the accommodation part, where a lot of people will fall short of it. You'll have a lot more on the eye exam and some of the different testing, such as the visual field testing in neuroanatomy. Now, pink eye and conjunctivitis are essentially a very important and common infection of the eye. There's a couple different components to the conjunctiva. There's the bulbar conjunctiva, which is against the eye itself, and there's the palpebral conjunctiva, which is against the lid. Pink eye has a number of different causes, which include virus, bacterial like gonorrhea and chlamydia can even get in there, irritants such as shampoo, dirt, smoke, or all sorts of chemicals, allergies like dust, pollen, types of allergies that affect some people that wear contacts as well. Here you can see the palpebral fissure, which is just the space between the tarsal superior palpebrum and inferior palpebrum. Notice how there are smooth muscle cells along the tarsal plate, as well as glands that can get infected, causing cysts and styes. Here you can see what happens with a reddening of the bulbar surface and the palpebral conjunctiva associated with a pink eye, which can be very highly contagious. So as far as eye testing goes, there's a couple reflexes that you'll need to do. First is the corneal blink reflex, which actually has contact, and that's going to test cranial nerve V1 for its sensory contribution to the eyeball. And then you're going to be testing also the motor loop, which would be cranial nerve 7, which would help you close the eyelid. The pupillary light reflex is going to be testing cranial nerve 2 if it's letting light in. Since you're going to shine the light into the eye, it should constrict with extra light, and it should dilate when the light is low. So if you increase the light, then it's going to constrict with parasympathetics, and if you decrease the light, it's going to dilate with sympathetics. The startle reflex, also known as the blink reflex, is the one that you have no contact in. So you can startle someone by scaring them and they can hear you, which would check 8, or you can startle someone by going at them, and that would be checking cranial nerve 2. So there are two systems and two ways to mobilize that test. Then with the motor side of this blink reflex, you're going to be testing again cranial nerve 7 to ensure that the lids can be closed. We'll move on to the ophthalmic view of the retina, Here in the upper left corner you can see an ophthalmic view, and then the netterized drawing where we can see the optic disc, which tends to be pale and is representative of the blind spot. There is all of the axons and vessels that are going in and out of the retinal nerve. Then you can see this spot called the macula lutea, and that macula lutea is going to be an important area because inside of it there's the fovea centralis, which is the highest center of visual acuity, and it's in that area where we only have cones, and cones are responsible for color recognition. Rods and cones, I remember C for color and C for cone. If we take a look at the orbital walls, you can see how each has a medial wall that's parallel with one another, and a lateral wall from each one which is at 90 degrees to the other. This is all sitting underneath the frontal plate, and with the two fields or axes in this, you've got your orbital axis, which goes along the eyeball and the optic nerve, and then you have the visual axis, which can be tracked by looking at where people are staring off to. You can see the muscles that are attaching off of the orbital ring on the sides of the eye, even though they're on a three-dimensional globe, will pull across one of those axes and only have two-dimensional movements. And the eye itself actually has three axes of rotation, an X, a Y, and a Z axis, which could be a longitudinal, transverse, and vertical. Along the longitudinal axis you get torsions, intorsion and extorsion. Along the transverse axis you're going to get elevation and depression, and along the vertical axis you're going to get adduction and abduction. When we look at the extraocular muscles themselves, you can see how there are going to be 7 of them, and it can be assisting to help remember them when you know the innervations by saying the little formula LR6, SO4, everything else by 3. That is going to stand for the fact that lateral rectus is done by cranial nerve 6, superior oblique is done by cranial nerve 4, and all of the other muscles are done by cranial nerve 3. So of the 7 extraocular muscles, one of them is going to the upper lid, which is the levator palpebrae superioris, and 6 of them go to the eyeball itself. 2 are obliques, and 4 are recti. This is the left eye, so what we'll do is we'll put these muscles in place. There's the levator palpebrae superioris, done by cranial nerve 3. Here we have the superior oblique, done by cranial nerve 4. Then we can see the inferior oblique, done by cranial nerve 3, superior rectus, inferior rectus, lateral rectus, and medial rectus. Of all of these muscles, it's only the medial and lateral recti that pull straight against the two angles to have two-dimensional motion. That means that all of the other muscles have three-dimensional motions. So to test them, you've got to do something to prevent that third dimension of torsion from messing up the count. Now what we're going to do is we're going to look at all these intraocular muscles which are inside the eye, and all of those are going to be smooth muscle. When we look at the back of the orbit, you can see the superior orbital fissure, which will have several branches of the nerves coming through there. And then you can see the tendinous ring, and only a couple muscles come from outside the tendinous ring. All of the others attach along it, which would be along the orbital axis. So we have levator palpebrae superioris, which doesn't attach to it. We have the superior oblique that doesn't attach to it. And not shown, we have the inferior oblique, which is coming off of the nasal bone and running inferior lateral across to the eyeball. Here you can see structures coming through the central tendinous ring, including the ophthalmic artery, which will give off a small branch that will penetrate into the optic nerve and be called the central retinal artery. This, of course, can be occluded, causing hemianopsia and transient ischemic attacks. the venous system, the ophthalmic vein, is running on the outside of that central ring through the superorbital fissure. So we have several branches of the nerves outside and several branches of the nerve inside the ring, and here they are being demonstrated by the various animations. Remember, it's the abducens nerve that will go to the lateral rectus, and the trochlear nerve which will go to the superior oblique. Everything else is by cranial nerve 3. When you do the H test, you're actually testing both eyes simultaneously. And what you want to do with the H test is all you need to do is organize it so that the muscle's pull angle is aligned with the visual axis. And how do you do this? Well, with the H test, by understanding where the muscles attach, you can take out all of those torsional components. So when you move your finger across to the right, you're going to have the right eye laterally abducted, which will take a lateral rectus, and the medial left eye will become adducted with the medial rectus. Then if you take the finger upwards, you're going to contract the superior rectus on the right eye and the inferior oblique on the left eye. Then when you come down, you would do the inferior rectus on the right eye and the superior oblique on the left eye. It's this down and in function that gets lost when you have a superior oblique injury or a trochlear nerve injury. So the H test is thereby testing both eyes simultaneously, and as soon as you cross the midline to do the other side of the H, you'll test them in reverse of what we just did. So again, the only thing you have to do to control the H test and know what's happening is to align the angle of the muscle's pull with the visual axis. You align the muscle by knowing what's happening, and then the visual axis you can track by having them look to a certain location and follow your finger. If you have damaged eye muscles, there's all sorts of problems that can present. You're basically looking for wonky eye. Also, you should be looking for head tilts as a red flag feature of a trochlear nerve damage, because what's going to happen with the trochlear nerve damage is that you're going to have the superior oblique knocked out, and that won't allow you to go down and in, so you're actually going to tort your head position to the side of the injury in order to accommodate for unopposed extorsion of that eye that does not have innervation. Patients will sometimes complain of dizziness while they're going downstairs, and they'll oftentimes get sore necks because they're having to adjust their vision so they don't have diplopia. The central damage is the damage to the trochlear nuclei, and that can affect the contralateral eye. All of the other nuclei of the cranial nerves are affected by ipsilateral structures. With abducens injuries, you're going to have a adducted eye. And this is a commonly injured one because of its long subarachnoid course compared to the other cranial nerves. Patients are going to have horizontal diplopia and an adducted eye because they have unopposed adduction when they lose their abductor. The oculomotor nerve, when it's out, the eye is going to present down and out, and that will look like this. So there may be a loss of pupillary light reflex as a result of losing cranial nerve 3 because, of course, the parasympathetics are coming in on that nerve as well. And then it will be hitchhiking with the ciliary branches as they go to the base of the eyeball.